So let's finish up, Jorge. Just a couple of comments about what we're excited about, what's coming soon.
Well, I think there's, I'll emphasize a couple of areas where there's attractive new drugs and interest in approaching as part of the holistic management of AML. One is targeting the microenvironment. We know that the microenvironment plays a role in protecting the cells from some of these targeted therapies. So there's been some interest in attacking CXCR4 and selectings and all of that. There's actually an interesting study here at ASCO with a drug called CX01, which is a randomized study of these patients. And there's 3 arms. There's one of standard chemotherapy, that's frontline standard chemotherapy, and then standard chemotherapy with 2 different doses of this agent. And they show that with the higher dose, there's a very attractive improvement in the response rate. That it's close to 90%. So it's a small study, preliminary, but attractive. And there's other approaches at CXCR4 and BL8040 and a few other drugs. And then immunotherapy, I think it's a broad area that's very attractive. And here, of course, we talked a little bit about the antibody-drug conjugates like gemtuzumab. You could argue that that's not immunotherapy, but it's a carrier antibody. But still, there are many others coming along the way that look also very promising. But very importantly, these bispecific monoclonal antibodies. We talked about blinatumomab in ALL, and there are several coming that target different targets in AML. It's been a little bit more difficult to find something that's safe and effective in AML, but there are some targeting CD33, CD123, and some novel targets like CLEC12A and a few others. Very attractive early data, still to be mature, but I think we're going to see something there. And then, of course, we've done studies with the checkpoint inhibitors, very effective, of course, in many tumors. There is some early data to suggest that they may have a role in AML, in MDS, in other hematologic malignancies. We're still trying to figure out where, how, combining them, with what. But I think there is a life to these drugs. We just don't have them quite yet ready. And then in the future, CAR T cells are being developed in AML. It's been challenging because, again, there's no specific target, but they're on their way, and there's things that are being done to develop these drugs. So things are going to look good, and we're going to have to integrate all of these different approaches to improve the outcome of our patients.
Yeah, CX01 reminds me of the data presented by Dan D'Angelo at ASH last year with GMI 1271 or uproleselan, which is an E-selectin inhibitor. Yep. Now that is being studied in the cooperative groups in previously untreated older AML patients with 7 and 3, and also there's an industry-sponsored study in the relapsed setting. Yep. Well, we have gone way over time, and usually we like to turn to each panelist and let them have closing remarks, but I am going to take the prerogative of the chair and maybe just make one broad comment. These are challenging times for us. 8 new drugs, complicated disease, and you add in on it that this is a rare disease for most oncologists. They see maybe 1 or 2 cases a year, maybe a little bit more, but not their breast cancer or colon cancer. And there's all this information on diagnostics, and then you add to all of that the urgency of making the diagnosis and actually starting treatment in still an urgent amount of time. It's not like breast cancer where you start chemotherapy 6 weeks after surgery. It's like within a week or so. And so what I would encourage our viewers to do is that if you are not in a center of excellence that sees a lot of leukemia, have leukemia programs, partner with someone in your community, in your area. Find your favorite leukemia doc, call them up, call them frequently, him or her, text them, ask questions, because these are important decisions to be made for our patients, and even send them to academic centers for consideration in clinical trials. We all know that most of these patients will go back to their doctors because it's hard to be put on a clinical trial. But I think we really need to do a better job of partnering with our community colleagues to give the best care for patients with acute leukemia.
Definitely.
Yes.
Really, that's all you have to say? Okay, we'll stop there. Okay, so on behalf of the panel, Thank you for joining us today. We hope you found this OncLive Pair Exchange discussion on AML to be useful and informative.